Thanks, everyone. We will now reconvene the ACIP meeting and specifically the vote in the discussion section. So let me ask, so we are going to actually switch the order of the votes compared to the agenda. So we will do the Zoster vote first, and then we'll move to the pneumococcal vote. So if you could please put up the Zoster vote. Before we move to the vote, I wanted to ask Dr. Anderson just to respond to an earlier question from Ms. McNally, as well as just read a clarification of the rewording of the recommendation, which is exactly the same, but just wanted to make sure that that was fully clear and stated.
Great. Thank you, Dr. Lee. Yes, we just wanted to follow up on the question regarding vaccine co-administration, just to clarify a note from our CISA colleagues that there is an ongoing study that'll be looking at co-administration of Shingrix and Fluad, and then Shingrix and Fluzone in individuals 65 and up. The caveat is that it's not a study in immunocompromised patients, but so there is some safety study activity there, and that's an ongoing study over the next couple of flu seasons that's enrolling. And then just to also reiterate, as we've talked about in the past, that we will continue to monitor any safety issues in the usual systems like VAERS and VSD. So,
thank you. Could you please put up the slide with the vote language? Dr. Anderson, would you like to read the proposed recommendation for vote?
Yes, we received an email just commenting on the order of the wording, so we went ahead and made that change just to make sure that this is clearly worded. So 2 doses of recombinant zoster vaccine are recommended for the prevention of herpes zoster and its complications in adults aged 19 years and older who are or will be immunodeficient or immunosuppressed due to disease or therapy. So just a slight rewording to make that a clearer statement.
Thank you, Dr. Anderson. I want to just confirm whether the committee has any additional questions or if the committee would be ready to vote. Okay, I'm not seeing any hands raised, so I will assume the committee is ready to vote on the motion on the table. ACIP members, I'm going to ask you to please state your name, whether you have a conflict of interest, and then your vote for the proposed recommendation listed here on zoster vaccine. And I'm supposed to remind everybody to put their video on, including me. I cannot find my video. Okay. All right, terrific. I believe we have the numbers up. May I confirm? To the vote. Okay, terrific. So we will begin, and as a reminder, it's your name, whether you have any conflicts, and then your vote for the proposed recommendation. And I will start with Dr. Paling.
Kathy Paling, no conflicts, yes.
Thank you. Dr. Sanchez.
Sanchez, no conflict, yes.
Thank you. Dr. Talbot.
Talbot, no conflict, yes.
Thank you. Dr. Alt.
Alt, no conflicts, yes.
Thank you. Ms. Bata.
Bata, no conflicts, yes.
Thank you. Dr. Bell.
Bell, no conflicts, yes.
Thank you. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Chen.
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Sineas.
Sybil Sineas, no conflict, yes.
Thank you. Dr. Daly.
Matt Daly, no conflicts, yes.
Thank you. Dr. Cotton.
Camille Cotton, no conflicts, yes.
Thank you. Dr. Lair.
Me Lair, no conflicts, yes.
Thank you. Dr. Long.
Sarah Long, no conflict, yes.
Thank you. Ms. McNally.
McNally, no conflict, yes.
Thank you. And Lee, no conflicts, yes. So this proposed recommendation now passes 15 yeses, 0 noes. Any other questions or comments, Dr. Wharton? Okay. Thank you very much. Actually, before I move on, I wanted to ask if any individuals, any ACIP members would like to make a comment or provide any further explanation for their vote. I just wanted to give the opportunity. You do not have to take it if you don't want to say anything else. Okay. I don't see any hands raised, so very little controversy on this one. So thank you very much to our ACIP members. And we are going to move next to the, are we good? Okay. To the pneumococcal vote. Are we good to proceed? Okay. Let's get that vote up on the screen for everyone to see. As a reminder, this is the proposed age-based recommendation vote. And I will ask if Dr. Kobayashi would be willing to read that vote for the committee to vote on.
Yes. Adults 65 years of age or older who have not previously received a pneumococcal conjugate vaccine or whose previous vaccination history is unknown should receive a pneumococcal conjugate vaccine, either PCV20 or PCV15. If PCV15 is used, this should be followed by a dose of PPSV23.
Thank you. And we'll start with Ms. Bata.
Bata, no conflict, yes.
Thank you. Dr. Bell.
Bell, no conflicts, yes.
Thank you. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Chen.
Gilbert Chen, no conflicts, yes.
Thank you. Dr. Sineas.
Sybil Sineas, no conflict, yes.
Thank you. Dr. Daly.
Matt Daly, no conflicts, yes.
Thank you. Dr. Cotton.
Camille Cotton, no conflicts, yes.
Thank you. Dr. Lair.
Amy Lair, no conflicts, yes.
Thank you. Dr. Long.
Sarah Long, no conflict, yes.
Thank you. Ms. McNally.
McNally, no conflict, yes.
Oh, thank you. Dr. Paling.
Paling, no conflicts, yes.
Thank you. Dr. Sanchez.
Pablo Sanchez, no conflict, yes.
Thank you. Dr. Talbot.
Talbot, no conflict, yes.
Thank you. Dr. Alt.
Alt, no conflicts, yes.
Thank you. And Lee, no conflicts, yes. So this proposed age-based recommendation passes 15 yeses, 0 noes, and will confirm. And I'll actually ask if we should take the next vote and then offer time for discussion. Okay, that sounds great. All right, so we will then move on to the proposed risk-based recommendation. Dr. Kobayashi, would you be willing to read through the risk-based recommendation?
Yes. Adults aged 19 to 64 years of age with certain underlying medical conditions or other risk factors who have not previously received a pneumococcal conjugate vaccine or whose previous vaccination history is unknown should receive a pneumococcal conjugate vaccine, either PCV20 or PCV15. If PCV15 is used, this should be followed by a dose of PPSV23.
Thank you very much. Any questions or clarifications needed before we proceed with the vote? Okay, I see no hands raised, so we'll move on to the vote. And this time I will start with Dr. Sanchez.
Sanchez, no conflict, yes.
Thank you. Dr. Talbot.
sorry. Talbot, no conflicts, yes.
Thank you. Dr. Alt?
Alt, no conflicts, yes.
Thank you. Ms. Bata?
Bata, no conflicts, yes.
Thank you. Dr. Bell?
Bell, no conflicts, yes.
Thank you. Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Chen?
Chen, no conflicts, yes.
Thank you. Dr. Sineas?
Sineas, no conflicts, yes.
Thank you. Dr. Daly?
Matt Daly, no conflicts, yes.
Thank you. Dr. Cotton?
Cotton, no conflicts, yes.
Thank you. Dr. Lear?
Amy Lair, no conflicts, yes.
Thank you. Dr. Long?
Sarah Long, no conflict, yes.
Thank you. Ms. McNally?
McNally, no conflict, yes.
Thank you. Dr. Paling?
Filling, no conflicts, yes.
Thank you. And Lee, no conflicts, yes. And this proposed risk-based recommendation now passes with 15 yeses and 0 nos. Thank you very much to our committee members. I would like to again offer the opportunity if individuals would like to comment on their vote or make any additional comments for us to open up the floor to our committee members. Dr. Brooks.
Yes, though I voted yes, I do have some concerns that the disparities in outcomes related to pneumococcal disease, invasive pneumococcal disease, may not be totally addressed by our/my vote, although there seems to be evidence related to hypertension and obesity not being at higher risk for invasive pneumococcal disease. I believe I'd like to see it and then theoretically revisit the underlying conditions at some time in the near future.
Thank you for that comment. Dr. Talbot.
I just want to point out one fact. We've really used the age 65, not for scientific reasons, but because that was the age chosen for Social Security and Medicare. And in 1935, the reason why 65 was chosen was that the average life expectancy of a man was about 60 and a woman 64. So it's not a very scientific way for us to move forward with adult immunization. It made sense at one time, but I think going forward, we really need to be more science-based when we look at our adult immunization and really reevaluate what's the correct age that we can vaccinate to improve healthcare in our adults and older adults. Thank you.
Thank you. Dr. Cotton.
Similar to the request by my colleague, Dr. Brooks, I would like to make sure that we accumulate clinical data because we are making a recommendation for immunocompromised and other at-risk patients largely on immunogenicity. And so I think that we really need to monitor this situation and make sure that we continue to see robust clinical protection as well as immunologic data. Thank you.
Thank you. Dr. Lair.
I'd like to thank the pneumococcal work group for all their hard work. It was a very difficult process getting all this data corralled and presented in a way that was made sense for us to vote on. So I want to give them a great shout out. I also would like to remind everyone that we want to revisit this in 5 to 7 years after the children have received the vaccinations and see if this recommendation is still necessary at that time. Thank you.
Thank you. Dr. Long?
Yes, I'd just like to point out it is increasingly important for those who take care of adults who will or will not be impacted by this decision. If there is invasive pneumococcal disease, that those isolates be saved and sent for serotyping, because this is not a completely preventable disease. And we know that in immunocompromised patients specifically,
the likelihood that they have non-vaccine serotypes of invasive disease is quite high, so that our clinical observations, which are so important of what we are seeing and how that is or isn't covered by the vaccine, will only be relevant if we have serotyping of those isolates, something that's much less likely to be done.
Thank you, Dr. Long. Dr. Daly?
So two quick comments. One is I just want to thank my colleagues on the ACIP. You know, I think every time one of you speaks, I learn something new or I have a new perspective on things. The other thing is that I think sometimes we feel like once we've made a vote or a decision, then the work ends. But really, I would say now the work just continues. And everything that my colleagues have mentioned are all things that we now need to monitor very closely. And I would add another, which is coverage in 50 to 64-year-olds with chronic medical conditions, right? We need to monitor that closely to see if this is achieving our goals. So, the work continues, and let's just keep adding on to the things that we need to carefully monitor. Thanks all.
Thank you. And I wanted to just add an additional comment, and I was conferring with my CDC colleagues in the room about what Dr. Daly had just mentioned and what others had just mentioned, starting with Dr. Brooks, that we need to continue to review the data on effectiveness and not just immunogenicity, that we need to monitor access and potential disparities carefully over time, and that this is a dynamic decision-making process, and we need to reconsider these decisions when the time comes. I also just want to state that at some point in the future, it may make sense for us to lower that age group, but given the data we had today, I felt very comfortable with the decision that we made on the age-based and risk-based thresholds that we had. Are there any other comments or final points individuals would like to make regarding this particular vote? Okay, I see no.
This is Oliver Brooks. One quick comment, please.
Sure.
I again want to underscore how impressive the work from the work group was. Last time this was presented, it was all over the place. It was not their fault. I talked to them directly and said how difficult this was. The fact that they were able to distill it down to where we took those two votes and they were both unanimous, with some trepidation and some concern, I really want them to understand how deeply I believe the whole committee appreciates what they did, especially underscore Dr. Kobayashi.
Thank you. I know. Thank you very much, and we really appreciate those you ending on with those comments, Dr. Brooks. I want to thank Dr. Kobayashi, Dr. Paling, Dr. Anderson, Dr. Cotton for taking us through the votes today. And thank you again to all of our speakers, members, and liaisons for the robust discussion. Is there any further business or any objections to adjourning today's meeting from any members? I'm looking at Dr. Wharton. Okay, hearing none, today's ACIP meeting is now adjourned. We look forward to seeing you all again tomorrow. Have a nice